Ever wondered how hospitals choose the right antibiotics to fight deadly infections? It all starts with an antibiogram, the secret weapon behind smart, life-saving decisions in microbiology labs. In this video, I'll break down exactly how to prepare an antibiogram step by step, whether you're a student, lab tech, or just obsessed with science. Stick around. By the end, you'll know how to turn raw lab data into powerful clinical insights. Ready to upgrade your lab game? Let's dive in. Every single year, over 1.27 million lives are lost. Not to war, not to natural disasters, but to something we thought we had conquered: antibiotic resistance. That's right. Bacteria that no longer respond to life-saving medications are silently becoming one of the greatest threats to global health. The consequences are staggering. Infections that used to be simple to treat now lead to longer hospital stays, skyrocketing healthcare costs, and far more complicated recoveries. But here's the truth: we are not powerless. We can fight back, with data. When we use data to guide our antibiotic choices, we don't just treat infections, we outsmart resistance. And that's where antibiograms come in. An antibiogram is more than just a report, it's a life-saving tool. It empowers hospitals, doctors, and entire communities to use the right drug at the right time, for the right bug. So if you're ready to make a real impact, whether you're a healthcare worker, microbiologist, student, or just curious, stay with us, because in this video, you'll learn exactly how to build an antibiogram, step by step. Let's dive in. Before we dive into the how, let's answer a critical question: what exactly is an antibiogram? An antibiogram is a concise summary, a scientific snapshot, that shows which bacteria are most commonly found in a healthcare setting, and more importantly, which antibiotics still work against them. Think of it like a bacterial scorecard, built using real-world lab data. It tells doctors, here's what bugs we've seen this year, and here's what kills them. Antibiograms are typically based on clinical isolates collected over one full year, so they reflect the local resistance trends happening right now. They aren't just helpful, they're essential. Antibiograms guide empirical therapy, the initial treatment given before lab results come back. They're also key tools in antimicrobial stewardship, helping us preserve our antibiotics by avoiding misuse. Infection control teams use them to track outbreaks, detect unusual patterns, and make smarter, faster decisions in real time. In fact, the CDC calls the antibiogram one of the most powerful tools in hospital epidemiology. Why? Because it helps us do three things incredibly well: prevent infections, protect antibiotics, and save lives. That's what an antibiogram does. It transforms raw lab data into actionable insights that defend patients from deadly, drug-resistant infections. So now that we understand what an antibiogram is, let's break down exactly how to build one. Now that we know what an antibiogram is, let's explore why we build one in the first place. An antibiogram isn't just a chart. It's a strategic weapon in the fight against infectious diseases. First, it helps clinicians choose the right antibiotic before the lab results are even back. This is what we call empiric therapy, that crucial window when time is of the essence, and every hour counts. An antibiogram shows which drugs are most likely to work, based on real local data, so doctors can act fast and act smart. Second, antibiograms help us track how resistance is changing over time. A certain bacteria becoming more resistant, a previously reliable antibiotics starting to fail. Antibiograms give us the long-term view, revealing the direction of resistance in your hospital, region, or country. Third, antibiograms play a foundational role in antimicrobial stewardship. That means using antibiotics wisely, only when needed, and only when they're likely to work. Stewardship isn't about saying no to antibiotics. It's about saying yes to the right one, at the right dose, at the right time. Finally, antibiograms help inform infection prevention strategies. If certain bacteria are spiking in resistance, infection control teams can implement targeted interventions. This kind of insight helps hospitals stay one step ahead, protecting patients, staff, and the broader community. So whether it's guiding treatment, identifying threats, shaping policy, or protecting antibiotics for the future, the antibiogram is a multifunctional powerhouse that every healthcare system should use. Next up, let's walk through exactly how to prepare an antibiogram, step by step. Okay, let's build an antibiogram. Step by step. Step 1. It all starts with a solid foundation. You have to define the scope. First, ask yourself, which hospital units are you including? Just the ICU, the NICU, or the entire hospital? You can build unit-specific antibiograms, which are great for high-risk areas, or create a facility-wide report to get the big picture. The key is to define your audience, who will use this data to make decisions. Next, should you separate adult and pediatric data? Absolutely. If your hospital treats both groups, they should never be lumped together. Why? Because the bacteria, and the way they respond to antibiotics, can vary drastically between age groups. Now let's talk bugs. Which organisms should you include in your antibiogram? Focus on those that are clinically significant and have at least 30 isolates during your study period. That number helps ensure the results are statistically reliable, not just random noise. Think of pathogens like Escherichia coli, Klebsiella, Pseudomonas, Staphylococcus aureus, the ones that cause real problems in real patients. And finally, define your time frame. The gold standard is a 12-month calendar period. This ensures your data is comprehensive, reflects seasonal variation, and gives a full year's view of resistance trends. So to recap, step 1. Number 1. Choose your hospital units. Number 2. Separate adults and kids. Number 3. Pick organisms with enough data. And Number 4. Use a consistent 12-month window. With your scope clearly defined, you're ready for step 2. Collect and clean the data. Because the quality of your antibiogram depends on the quality of your input. Now that you've defined your scope, it's time to roll up your sleeves and get into the data. Step 2. Collect the isolates. But not just any data will do. First and foremost, include only the first isolate per patient, from each body site, during your 12-month study period. This is called deduplication, and it's critical. Why? Because if a patient has 5 cultures from the same infection, we don't want those to skew the data or inflate resistance rates. 1 patient, 1 organism, 1 site, per year. That's the rule. Next, exclude any surveillance or environmental cultures. These aren't true clinical infections. They're used for screening or environmental monitoring. Including them would misrepresent real-world infection patterns and undermine your antibiogram's accuracy. Your antibiogram should be based on clinical isolates only. That means samples from patients who are actually being treated for an infection. Think blood cultures, urine cultures, wound swabs. Not screening swabs or surface samples. How do you pull and clean this data efficiently? Use tools like WHONET, your laboratory information system, abbreviated as LIS, or even custom SQL queries. These platforms can help you automate deduplication, organize isolates, and apply filters, so you're working with clean, accurate, and non-redundant data. So in step 2, you're not just collecting data, you're curating it. Number 1. One isolate per patient. Number 2. No surveillance or environmental samples. Number 3. Only clinical, infection-related isolates. And number 4. Use digital tools to streamline the process. Get this part right, and your antibiogram will be built on solid ground. Now that you've collected your clinical isolates, it's time to move to step 3, identify and test. This is where science meets precision, and accuracy is absolutely everything. First, you need to accurately identify the organism. This is the who of the antibiogram, and we can't fight resistance if we don't know the bug. Use modern tools like MALDI-TOF mass spectrometry, classic biochemical tests, or PCR-based methods, depending on your lab's capabilities and infrastructure. The goal here is simple: species-level identification with high confidence. Next, it's time for AST, antimicrobial susceptibility testing. But don't just wing it. Follow internationally accepted guidelines from either CLSI or EUCAST. These standards define which antibiotics to test, how to test them, and how to interpret the results, ensuring your data is reproducible, reliable, and respected worldwide. Every lab knows. If you're not running quality control, you're just guessing. Be sure to include reference strains like Escherichia coli ATCC25922, Pseudomonas aeruginosa ATCC27853, or Staphylococcus aureus ATCC29213. These strains serve as your internal checkpoints. If your QC results fall outside the accepted range, pause immediately. Something went wrong. And what methods can you use for antimicrobial susceptibility testing? Choose the platform that fits your lab setup. Number 1. Disk diffusion for low-resource or manual workflows. Number 2. Vitek 2, BD Phoenix, or Microscan for automation. Or, number 3. Broth microdilution, the gold standard for precision. What matters most is that you follow the correct protocol, use updated breakpoints, and test the right antibiotics for each organism. So to summarize step 3, number 1. Identify your organisms with confidence. Number 2. Test their resistance using validated methods. Number 3. Always use quality control strains. And, number 4. Stick to global standards from CLSI or EUCAST. You've now got high quality, accurate results. Coming up next, I will show you how to organize this data and transform it into an antibiogram that people can actually use. Alright, we've collected our raw data. Now comes a critical step that can make or break your antibiogram: cleaning and aggregating your data. Think of this as sanitizing your house before hosting a guest. Only this guest is clinical decision-making. Start by scrubbing your data. You want to remove any isolates with missing susceptibility results, contaminated cultures, or samples that aren't from clinical sources. That means say goodbye to environmental samples, surveillance swabs, and anything from research-only projects. If it's not directly tied to a patient's clinical care, it doesn't belong here. Only clinical, high-quality, patient-centered isolates should make the cut. When you're summarizing antibiotic performance, Focus only on percent susceptible. We don't include intermediate or resistant percentages here. Why? Because susceptibility is what guides initial therapy choices. Fast. This gives clinicians a crystal clear snapshot of how likely an antibiotic is to work against a particular organism. Now, here's a golden rule. Only include organisms that have at least 30 isolates tested. Why 30? Because smaller sample sizes can be misleading. Just a couple of resistant bugs could skew your entire data set. For example, if out of 10 isolates, one is resistant, it implies 90% sensitivity versus a case in which 3 isolates are resistant, which corresponds to 70% sensitivity. Big swing. Stick to the equal to or more than 30 rule to boost statistical reliability and confidence. Finally, let's talk math, but don't worry, this part's easy. To calculate percent susceptibility, just use this simple formula. The formula is as follows. Percentage susceptible is equal to number of susceptible isolates divided by the total number of isolates tested, all multiplied by 100. For example, if you tested 100 isolates of Escherichia coli, and 82 were susceptible to ciprofloxacin, your percentage susceptible is 82%. Clean, simple, powerful. So in step 4, your job is to clean ruthlessly, count smartly, and calculate precisely. The goal, a rock-solid data set that reflects true clinical realities and empowers smarter prescribing. We've cleaned the data. We've run the numbers. Now it's time to make it all come together visually. Welcome to step 5. Formatting your antibiogram, where raw stats become clinical gold. First things first, presentation matters. Your antibiogram should be clean, organized, and readable at a glance. Think of it as your lab's cheat sheet for empirical treatment. Use a simple font, avoid clutter, and keep the layout tight. No one wants to squint at spaghetti data, especially not a clinician making decisions at 2 a.m. The standard format is easy to remember. Rows are for organisms, and columns are for antibiotics. This layout lets you quickly scan and compare susceptibility rates across multiple agents and organisms. Use color coding for resistance levels. Now here's where you take it to the next level, color coding. This simple visual cue makes your antibiogram instantly actionable. Red for less than 70%, yellow for 70 to 90%, and green for greater than 90%. Here's the rule of thumb. Green means go. If susceptibility is above 90%, green, it's likely to work. Yellow means caution. Between 70 and 90% yellow, there's a risk. Use wisely. Red means stop. If it's below 70%, red, avoid unless there's no other option. This visual hierarchy helps prescribers make smart, fast choices, and reduces the risk of resistance spreading. Remember, your antibiogram isn't just a table. It's a clinical decision tool. It has the power to change prescribing behavior, reduce antibiotic misuse, and even save lives. Coming up next in step 6, after the sample antibiogram format table, review and validate your data. Because even perfect tables need a second set of eyes. Pause the video and carefully scrutinize the table which shows a sample antibiogram format before progressing to the next slide. Your antibiogram looks polished, color-coded, and ready to go. But wait, don't publish it just yet. There's one last, mission-critical step before you hit send: internal validation. This isn't a solo job. Pull in your antimicrobial stewardship team, your clinical microbiologists, and your infectious disease clinicians. Why? because each brings a unique lens to the data. This step isn't just a review, it's a clinical gut check. Now dig into the details. Review for typos, formula errors, and statistical outliers. Does something seem off? A 100% susceptibility to vancomycin for Escherichia coli. That's not just unusual, it's impossible. Look for weird trends, unexplained jumps, or dips that don't match clinical expectations. Next, highlight high-consequence resistance threats. We're talking CRE, MRSA, VRE, ESBLs. The dangerous acronyms that strike fear in any hospital. If you detect these in your dataset, flag them clearly. Use footnotes, separate rows, or a dedicated watch list box on your antibiogram. Warning: these bugs don't play by the rules. Finally, compare this year's data to past reports. Are the patterns consistent? A sudden 20% drop in susceptibility might be a real trend, or just a data entry error. Understanding historical context keeps your antibiogram grounded in reality, not just raw math. When your teams reviewed the data, caught errors, confirmed trends, and flagged threats, you're ready. Your antibiogram isn't just a table. It's now a validated clinical tool, backed by a team of experts and real-world context. Coming up in Step 7. How to share and disseminate your antibiogram. Because what good is a powerful tool if no one sees it? You did it. The data's clean. The formatting's flawless. It's been reviewed, validated, and is ready to go. But an antibiogram is only as powerful as the people who actually use it. Welcome to Step 7. Disseminate and implement. Let's get this tool out of the spreadsheet and into action. Start by going old school. Print it. Yes, hard copies still matter. Post your antibiogram in key clinical areas like the emergency room, ICU, inpatient wards, and primary care clinics. Make it visible, accessible, impossible to ignore. Think. Next to the crash cart. Why not? Next, go digital. Integrate the antibiogram into your electronic medical record, abbreviated as EMR, and, if available, your hospital mobile app. Clinicians should be able to pull it up with one click, at the bedside, in the operation room, or during morning rounds. The more convenient it is, the more often it gets used. Here's a secret. Just posting the antibiogram isn't enough. Train your staff. Host quick workshops, micro-learning sessions, or even 5-minute morning huddles. Teach clinicians not only how to read the table, but how to apply it to empiric prescribing. Remember, an antibiogram is not a wall decoration. Last but not least, keep it current. Update your antibiogram at least once per year, and make it part of your official antimicrobial stewardship strategy. Regular updates help detect shifting resistance patterns, spot emerging threats, and track the impact of your prescribing practices. So to wrap it up: 1. Print it. 2. Digitize it. 3. Teach it. And 4. Update it. Your antibiogram is no longer just a tool. It's a clinical force multiplier. Congrats! You've now mastered the full process of building and implementing an antibiogram. From raw data to real-world impact. Now go empower your team, improve empiric therapy, and fight back against resistance, one antibiogram at a time. Your hospital isn't one size fits all, and neither should your antibiogram be. Welcome to the power of unit-specific antibiograms. Some units house your most vulnerable patients. Those who are immunocompromised, intubated, or newborn. We're talking about the ICU, where multi-drug resistance runs rampant. Oncology wards, where neutropenic fever is a daily risk. NICUs, where infections strike the tiniest, most fragile lives. These units have unique flora, unique risks, and often unique pathogens. That's why you need to generate custom antibiograms specifically for them. When building a unit-specific antibiogram, it's not just about breaking the data down by location. It's about being strategic. Focus on the bugs that matter most in that unit. And more importantly, on the drugs that are typically used. In the ICU, that might mean spotlighting pathogens like Pseudomonas, Acinetobacter, and resistant Enterobacterales, alongside carbapenems, Piperacillin tazobactam, and colistin. In the NICU, your focus shifts to organisms like Group B Streptococcus, Escherichia coli, and Listeria, with agents like ampicillin and gentamicin. In oncology, the stakes are high. You'll be watching for CO agulus negative staph, Pseudomonas, and fungal organisms, and reviewing options like vancomycin, cefepime, and amphotericin. This level of granularity helps clinicians fine-tune empiric therapy in the exact setting where time, precision, and outcomes matter most. It's precision medicine in action. Starting with data. Creating unit-specific antibiograms does take extra work, but it gives your hospital a data-driven edge. A smarter, sharper response to resistance that's tailored to each patient population. You've put in the work. The antibiogram is almost ready, but even the best datasets can be derailed by a few critical, and surprisingly common, mistakes. Let's break down the top errors that can seriously skew your results, or worse, misguide treatment. First up, don't mix your breakpoints. Using both CLSI and EUCAST standards in the same antibiogram. That's a no-go zone. These two systems use different breakpoints and methodologies. That means an isolate might be susceptible by CLSI, but resistant by EUCAST. Mixing them leads to inaccurate susceptibility rates and confusion. Mistake number 2. Reporting resistance percentages instead of susceptibility. It might sound like a small difference, but in clinical terms, it's a big deal. The antibiogram's job is to guide empiric therapy, and clinicians want to know what's likely to work, not just what's already failing. Third mistake, including repeat isolates. You should count only the first isolate per patient, per species, per specimen type, per analysis period. Why? Because repeat isolates can inflate resistance rates, especially if you're tracking a patient through a long hospital stay. One patient, 3 positive cultures for the same Klebsiella. You count it once. And finally, don't include organisms with fewer than 30 isolates. That's not just a suggestion. It's a gold standard rule. Why? Because small sample sizes lead to unreliable data. One resistant bug in a sample of 10. That's 90% susceptible. On paper. But clinically, way too risky. Let's recap the top 4 antibiogram mistakes to avoid. Number 1. Stick to one standard. CLSI or EUCAST, not both. Number 2. Always report percent susceptibility, not resistance. Number 3. Exclude repeat isolates. Only the first one counts. And, number 4. Use equal to or more than 30 isolates to ensure statistical validity. A great antibiogram isn't just about the data. It's about avoiding the traps that can derail clinical decisions. So double-check your methods, and you'll be well on your way to delivering a report your whole hospital can trust. You've built the antibiogram. You've validated every number. But what's the real-world impact? Let's talk about the big wins that come from a good antibiogram. Because this isn't just a report. It's a game changer for clinical care. First and foremost, a strong antibiogram improves empiric prescribing. That means when a patient shows up critically ill, before the culture results come back, your clinicians can make smarter, faster, data-driven treatment choices. Rather than relying on outdated habits or anecdotal memory, they're guided by local, real-time resistance patterns. This leads to quicker clinical action and better outcomes. A good antibiogram also helps reduce resistance pressure in your hospital. How? By discouraging broad-spectrum overkill. When prescribers know what actually works locally, they can avoid unnecessary broad-spectrum antibiotics, which means fewer opportunities for resistant organisms like MRSA, ESBLs, or CRE to emerge and spread. And here's where it all pays off. Better patient outcomes. Faster appropriate therapy leads to shorter hospital stays, fewer complications, lower readmission rates, and ultimately, lives saved. Data-backed care isn't just efficient, it's life-saving. A solid antibiogram is an investment that pays for itself. It reduces unnecessary testing, limits overuse of expensive antibiotics, and prevents costly complications. That means better outcomes for patients, and better resource management for your hospital. A well-used antibiogram saves time, saves lives, and saves money. So whether you're in pharmacy, microbiology, stewardship, or bedside care, a good antibiogram helps you make smarter decisions, faster, and with greater impact. Your antibiogram is more than a table. It's a tool for transformation. If you found this video helpful, hit like, subscribe, and share it with your team. Because better prescribing starts with better data. By now, you've learned the full process of building an antibiogram, from raw isolates to a validated, actionable clinical tool. But here's the question. Who should actually be using this? Let's break it down. First up, clinical microbiologists. You are the data architects behind every antibiogram. From identifying organisms to verifying susceptibility patterns, you ensure that the data is not only accurate, but meaningful. Accuracy starts in the lab. Next, infectious disease physicians. You rely on antibiograms to make life-saving empiric decisions for critically ill patients. In sepsis, neutropenic fever, postoperative infections, time is everything, and the antibiogram gives you the edge. Remember, right drug, right time, right now. This tool isn't just for practicing clinicians. If you're a medical or pharmacy student, the antibiogram is your entry point to real-world antimicrobial decision-making. Learn it early. Use it often. You'll be the prescriber someone else depends on. For infection preventionists, the antibiogram is a strategic surveillance tool. It helps identify rising resistance trends, track outbreaks, and guide isolation and control policies. In short, fewer surprises. Smarter responses. Detect, defend, prevent, and finally, antimicrobial stewardship committees. You're the bridge between lab data and frontline action. Antibiograms inform your empiric protocols, your formulary decisions, your education campaigns, and your results. A good antibiogram isn't just a tool. For stewardship teams, it's a strategy. So who should use the antibiogram? Everyone with a role in protecting antibiotics, improving patient care, and preventing resistance. That includes you. By now, you've learned the full journey. How to clean, calculate, validate, and implement an antibiogram. But great data doesn't just come from hard work alone. It comes from using the right tools. Here's a quick look at the essential resources you can use to streamline your process. First up, WHONET. This is a free, powerful software tool developed by the World Health Organization, designed specifically for managing and analyzing microbiology lab data. With WHONET, you can 1. Input raw susceptibility test results. 2. Automatically apply breakpoints. And 3. Generate clean antibiograms with just a few clicks. It is great for both local labs and national surveillance. If your lab has been using spreadsheets alone, this is your upgrade. Of course, if you need flexibility, Excel is still your best friend. Use it to 1. Apply formulas like percentage susceptible equals susceptible divided by total multiplied by 100. 2. Use conditional formatting to highlight resistance levels. 3. Filter, pivot, and sort by organism, site, or unit. Plus, it's easy to share across departments, or integrate into existing EMR dashboards. No antibiogram is valid without the right interpretive standards. That's where CLSIM 100 and EUCAST breakpoints come in. These are the gold standards for defining what counts as 1. Susceptible, 2. Intermediate, and 3. Resistant. Pick one system and stick to it. CLSI is commonly used in the US, while EUCAST is preferred in Europe and parts of Asia Pacific. Just remember, don't mix and match. Whether you're building your first antibiogram, or refining your annual update, these tools will save you time, reduce error, and boost your clinical impact. Remember, you don't have to start from scratch. The best antibiograms are built with the best tools. So explore them, download what you need, and start building data that makes a difference. And that's how you build a rock-solid, data-driven antibiogram. Step by step. Because in the fight against resistance, your lab's data isn't just information, it's power. Found this useful? Help your lab go data-driven. Drop a comment below and tell us, how does your hospital or university use antibiograms? What challenges have you faced? Share this video with your microbiology lab, stewardship team, ID faculty, or student group. Because when one person learns, the whole system gets smarter. Smash that like button. Subscribe for more lab-powered education. Join our growing lab community, where microbiology meets real-world impact. This is just the beginning. So stick around, stay curious, and keep pushing for smarter, safer care. One antibiogram at a time. Thanks for watching, and I will see you in the next one.